A very warm welcome from International Association of Pediatric Dentistry. Namaste from India. Starting session with famous inspirational quote from Michel Rouge. If people are doubting how far you can go so far that you can't hear from them anymore. One such inspirational person for all the aspiring and established pediatric dentists is Dr. Francisco Ramos-Gomez. Dr. Ramos is currently a full professor in section of pediatric dentistry at the University of California, Los Angeles. He is executive director of UCLA Center for Children's Oral Health and director of strategic partnership for interprofessional collaborative education in pediatric dentistry. During his career of more than 30 years in pediatric dentistry, he has focused on research in the areas of early childhood caries prevention, oral disease risk assessment, and community health with an emphasis on underserved population. In addition to clinically based intervention, he is also UCLA chair of the Division of Growth and Development. It might take the whole night if I start speaking about all his credentials, and I have been fortunate enough to spend good time with him during my UCLA visit. It's pleasure for all of us to be part of this session. We are highly thankful to Dr. Ramos for giving his time to enlighten us on community-based approach to reducing dental caries. Over to Dr. Ramos, please. We will take a question at the end of session. Okay, some of the questions and rest of the question we will answer via app. Over to Dr. Ramos, please.
Thank you so much, and I really appreciate it. Good morning, good afternoon, good evening to every one of you, especially my good friends very far east, I think India and Africa, that it's almost midnight over there. I'm so appreciative of you joining in tonight. So welcome all to our session on community evidence-based approach for ECC prevention. I want to thank the IAPD organizing committee. As you know, this session is being sponsored by Colgate, even though we have not got any remuneration whatsoever for us, the speakers. It's all going all for the IPD, so we're all donating our time for this. I really could not speak more about Colgate, about how relevant it is, the pioneer on all the wonderful things for children's oral health, especially Dr. Marsha Butler. She's inspirational. She's been an amazing colleague, partner. She's been really leading the Bright Smiles, Bright Futures from Colgate. As you know, they've been serving millions of children all around the world. And I think next year is going to be 30 years of BSBF, and we cannot do it without Dr. Butler. So I'm doing a shout out to her and all her amazing dedication, her passion, as well with the Alliance for a Cavity-Free Future. So I'm delighted to be part of the Colgate family as well with the IPD and be participating with you guys today. Thank you, Dr. Butler, for what you do and you continue doing for children's oral health around the world. So for my talk today, we're going to be doing a trajectory of early childhood caries research. As you know, that's been all the work we've been doing. We're going to discuss some early interventions of ECC, our 6 steps for infant oral care. And we're going to be telling you how we have switched very rapidly to this COVID response telehealth. What is the future of pediatric dentistry? What does it entail? What are the kinds of things that we can really implement? And finally, we're going to touch base on some policy implications. As you know, we follow the biobehavioral and environmental model of children's oral health from NIDCR, NIH, and the Academy of Pediatrics. So it's we have 3 levels: child level influences, the family level influences, and community level influences. So today, we're going to try to show you the combination of looking at population-based prevention as well as very individual patient-centered approaches. As you know, we're advocates for the H1 visit. It's something that we've been really trying with different organizations around the world to help us to promote the relevance, the importance, and the need of the H1 visit, as you know. So we follow this whole model, that child at the center, all the things, especially now, we're going to discuss through COVID, all the different stressors that families are going, food insecurities, housing insecurities, all our vulnerable families. This is relevant that we emphasize on really the improving the quality of oral health in each and every household, which involves diet, nutrition, and well-being of the child as well. But we're also in this great era of minimally invasive pediatric dentistry, where we are really working on identifying the disease, very good diagnosis, very good prevention efforts, and then you can then think about some restorations with minimal invasives. Right now that we're gonna be switching or trying to switch to minimal invasive practices and trying to minimize the use of aerosols in the practice. So what do we do for the H1 visit or first birthday? Just a little reminder that the Academy of Pediatric Dentistry, AAPD, as well as IAPD and many others have really promoted the H1 visit, the first tooth in the mouth, or as soon as the first birthday. This child, infant, and toddler should be seen in our practices for monitoring, tracking, all the things that we can do. We've been doing many studies. We've been blessed. I'm very grateful that we've been funded from NIH, NIDCR for the last 23 consecutive years. So we did a fluoride varnish study with Dr. Jane Weintraub. We did a Maya study focusing on mothers, pregnant mothers and their youth and their babies. We completed the glass ionomer sealants fluoride trial, where the GIFT study, where we show and demonstrate how the use of glass ionomers in primary, first and second months were very effective. And all that built our infant oral care program. We've been now working on infant oral care for over 25 years, almost a quarter of a century. And this is what our passion, our work we've been doing. And lastly, we are in the middle of finishing the Beacon study, which is behavioral economics. We're working with some of the best health economists to really find out what will be the incentives that parents will need and they will require to really brush their children's teeth every night. If you can imagine, a very simple thing as brushing child's teeth can be really a huge challenge for families from all different socioeconomic status and level of education. So we really want to emphasize what can we help and assist parents, almost like health coaching in toothbrushing practices. So part of our UCLA Community Infant Oral Care Program, we work in community health centers throughout Los Angeles. So we started this in San Francisco many years ago, where we really try to emphasize on a one-stop shop. We join forces with the pediatricians, DMDs, where we have, while they're having the wellness baby visit, parallel to that, we have the wellness baby dental visit. So before the first vaccination at 12 months of age, we immediately flag these children in our electronic child record, and the parents are asked to go to the dental service prior to go to the 12-month vaccination of the child. That has really changed our world, when either you can flag it and work in a medical dental integration way. It's so essential that you join forces and really try to see the children where they come, and that you avoid multiple visits for the parents at any given time. So this has been very, very, very successful for us. Some of the great community benefits for infant oral care practice are we can really ensure prevention measures. We start very early on. Early intervention, early monitoring, early tracking, early prevention are really key essentials for the success of any program. You can really monitor and track these children throughout their life cycle, their life course, which is so essential. And we also do that by improving the access to dental care, especially promoting the whole issue of dental home, right? Every child should really have at least a dental home starting very early on. We wrote some protocols almost 9 years ago into the future, where we really were the first ones to come with the creation of the risk assessment tool, which we did, and also with the self-management goals, as well as the creation of this recare system that each child is being seen every week at H1, and base the recare on risk assessment. So these are the 6 steps of infant oral care. We do Caries management by risk assessment, the camera model. As you know, we've been talking about this for some while. Regardless, whatever risk assessment tool you use, you can put in here, the one from the APD, the one from the ADA, the one from CAT, or other global places you can use. Proper position of the child knee to knee. We'll continue with an age-appropriate toothbrushing prophylaxis. We clean the child's teeth. We do a tell, show, do, where we tell the parents what to do, and then we show them before they do it, right? Then we do a clinical exam. Our residents are really trained like hawks to really look for those white spot lesions and track them very, very early on. This is the difference, a huge difference, where we really showcase to our residents and our students the need to monitor and to identify early any demineralization of the enamel at a very early age. Then we do the fluoride varnish treatment. And we finish, I think, with a very important anticipatory guidance, the counseling of the self-management goals. So these are the protocols that we instituted many years ago and have been adapted pretty much in the US as well as in many parts of the world. So remember, it's all about the white spot lesions. We really focus, we're very obsessed with them, and we try to teach parents to look for them, and if they show them, to bring them immediately. Remember, this is the first sign of disease progression that we need to be aware of, and we need to really find out which are the culprits causing this early demonization of the enamel. We followed the ICCMS. This is a fantastic, amazing tool of international caries classification and management systems, which really have the whole piece of ICDAS, where we can really learn in an international way to early diagnose and classify lesions appropriately. And for pediatrics, you know, you can say 0 is sound enamel, the ones and the 2s will be the demineralized. You know, one is while wet, the other one is while dry, that you can really show that demineralization of the enamel lesions. We try to do a very focused, patient-centered approach where we really do personalized treatment plans that really address the issues of the patient's needs and their preferences. She right? Had normal development. So this is one of the nurses that is doing some risk assessment in our tool. This is pre-COVID, as you know. We had a great way that we do in a pediatrician's office that we could do this. We don't really need to have a dental operatory. We do it in the cubicles for primary care with the pediatricians. So this is the first step. The caries management by risk assessment, as you know, is divided into 3 specific domains. One is the risk factors, so the pathological factors. We follow the Featherstone model of caries management by risk assessment, where in one hand you have all the pathological factors, then you try to balance them, the constant balance, with the protective factors. And the beauty about this is that in the past, we have very, very few different materials to address 0 to 5-year-olds. It's a big difference to really try to tease out what materials are there in manufacturers, where they'll say exclude most of these products for children under 5 years of age. So our biggest challenge has been how we can maybe extrapolate from those wonderful already materials that we have, calcium, phosphate, and fluoride, together that we can really place at an early age for younger children. And since there are not really any clinical trials to base 7 years of proof efficacy, right? So pretty much it's a lot of how we can really do age-specific, in an age-specific, risk-specific approach with the possibilities of the families to address these protective factors. But we have a whole array, and it's going to be part of our discussion, the whole array of protective factors that we can have at the moment. And then we'll have the clinical findings, right, where you can see and you can look at the tracking lesions appropriately. The second step is the need to knee. We position the child. A lot of the parents, you have to ask for permission to do this. So you put that child in your lap. They're usually going to cry. And that's one of the biggest barriers why dentists, our pediatric dentists, don't really still want to see them until later, because these babies are going to cry no matter what. But you have to just get used to it and make sure that you're doing less than what a pediatrician would do for their shots. So it's a very simple procedure. Then we do the toothbrush prophy, when we really train the parents. Parents are so appreciative when we teach them how to brush their child's teeth. Most of them says no one has really taken the time to really show them how to remove plaque, the circular brushing technique that you can really use, as well as to brush the child's tongue. No parent has really made me aware they knew this information, so make sure you really take the time to brush the child's tongue as well appropriately. This is what the form looks like. It's been now implemented and it's been translated in like almost 15 languages all around the world. So we're very proud of the risk assessment tool we have. Of course, it's a moving target. We try to update the form based on evidence, but in my lecture, through the app, you can really download some of the articles and the materials that are made in reference for. The fourth step is a clinical exam, where we're going to really go tooth by tooth and assess any of them to see if they have a fluoride, if they have any of the white spot lesions in there. And step number 5 would be the fluoride varnish application. As you know, you'll know how to apply varnish. I'm not going to take time to tell you more about the varnishes, but it's so important that you really tell them the vitamins for your child's teeth will be this amazing fluoride varnish, which I think we were the first ones through Colgate sponsorship with Dr. Weintraub to come up with the first fluoride varnish study back in 1990s. So we've come a long way of the long clinical trial of 7 years that was done in the States, where everything exploded to do the fluoride varnish application for all. And lastly, my dear friends, we really could not really do this without anticipatory guidance. I think this is the key for our success. We really spend time counseling parents and really using motivation interviewing techniques to really address the parents' needs and the parents' preferences. It's so important to highlight this. We used to give them 20 different messages, 20 different recommendations. The poor parents were so like, oh my God, overwhelmed. So now we say, if there's two things you can do for the following visit, what are the kinds of two things you could do? So as you see here, one in the red will be the importance of the last thing that touches your child's teeth will be fluoridated toothpaste. So we try to promote the universal use of fluoridated toothpaste. You'll be so surprised, and we're so saddened to know that many pediatricians and even dentists still are not recommending the use of fluoridated toothpaste under 3 years of age, which is a sin. It is a crime that we don't have to follow the guidelines. And I know people are just so concerned about fluorosis, but you know, for one case of fluorosis that we see, we might have 1,000 cases of early childhood caries. So you do the math in balancing the risk. So it's essential that you really are advocates and really promote the universal use of fluoridated toothpaste throughout the lifetime. The smear amount under 3, as I'm going to show you, as well as a pea size or half of the pea size. So this form that was created by our studies in the community health centers, which were really fantastic, they give us a sense that the parents are very willing to cooperate and to work with us, as long as we really spend some time explaining the reasons why we are doing this and to discuss their options. So we ask them from 0 to 10, how sure you think you can do this practice, and they give us a 7, 8, or 9, that's terrific. We move on to the next one. If they say only 2 or 3, maybe they're not ready for that change. So we move and we discuss with them what is the other one that they can do. They sign this as a contract. We sign it, they sign it. We give them a color copy with a magnet so they can have a reminder about the relevance of doing this every night. Remember, they're the ones with that child every single night, and you're not. So this is how capable you are in trying to convey this behavioral change, almost like behavioral scientists, all of you, to share this information with parents and to really trigger that the light switch is up and they get it, right? So a lot of very wonderful dentists, pediatric dentists tell me, but I educate my patients all the time. But maybe what we should question ourselves is how, not how well we educate, but how are we doing the education? I thought for many years I was doing great until I learned more about there's tools now and learning mechanisms of how to really trigger behavioral change appropriately for these parents. Remember, we have to really engage the parent so they can work on their third party, which is the child in there, which is an essential part of our whole equation. In the US, we have a horrendous epidemic of these, I call them junk on the pouches, where parents are feeding these children constantly, especially now with food insecurities in the household and people in quarantines are using these pouches as behavioral modifiers for the child. The child is fussy, there goes the pouch. Some of them have 40 grams of sugar in there, huge amount of calories. So if you remember Stefan's curve, for me, this is all the mantra, really coming back to our key chart of Stefan's curve, where we have a pH of 7, everything without any stimulus in the mouth will drop to a critical pH of 5 or 4.5, and it's gonna continue anything from 20 to 30 minutes before it goes back. But some of these families are really exposing these young children every 20, 30 minutes with food as a way of modifying the child's behavior. So we have to be very aware, especially for these challenging times, my dear friends, to ask the question about frequency of snacking and what kinds of snacks are these children exposed to. Be very aware of sugary foods and drinks, which are unfortunately prevail in our society, but trying to really address, at least have some sort of mechanism to monitor the amount of exposures these babies are getting every single day.
Is actually drinking tap water. So I know a lot of us think that drinking out of the sink is kind of gross, but actually it's really good because we have the water that we get from the sink has fluoride in it. So remember what I just put on her teeth? Fluoride is a material that's very good for making the teeth stronger. And so we want you to use the tap water. So say if you're going to boil a bottle for her, anything, water or whatever, use it from the tap. I mean, I also drink tap water. It's just they have things in it that are good for your teeth. And
in the US, we're very, very, very pleased that we have fluoridated water. So in most of the states, not all of them, but we try to really emphasize in tap water use. Besides, you always ask the question, besides milk and water, what else are you drinking? And really try to tap into any sugary drinks. It is really sad how many families are really introducing, especially now with families in quarantine, they're really being exposed to sodas and sugary drinks, which we have to be aware of. So, and for me, this is a very relevant thing. I will ask you a little trivia question. What do I mean by 2 versus 8,039? Okay, if you want to put it somewhere in the chat, the idea will be that you can say many, many things about this, right? But this for me was very relevant when I learned that we spend an average, me as a pediatric dentist, when every child, every family in a year, maybe an average of 2 hours in that 1 year. But the family, the parents are with this child 8,039. I strongly believe our biggest success will be how we can trigger in the parent to really act around those 8,000 hours and really work into oral health habits that are beneficial for every day, every night in the child's household. And this is something that we need to learn how to do better and much appropriately. So we developed, as part of our work, care paths. We thought it was really good, and I think a lot of people have been really working on this concept that at the end of the day, based on age of the child and based on risk, you're going to really think of and really going to develop a care paths, which are some specific tables that you can really follow suit. And this is what we wrote some years ago now, but based on risk, if you see in the left side column, the risk category, this is tables for 0 to 2. We want to make a differentiation that 0 to 2s are very different than 3 to 5s, right? 0 to 2s depend 100% in the mother or the caregiver. The 3 to 5s are more independent and they can do more things without almost the parent right there. So this is the risk categories: low, moderate, of high. This is the diagnostic, the prevention, all the things on preventive interventions before we get into restorations. One of the things we want to show you is that you have a whole array in the green zone. Nowadays, you have an amazing amount of resources that will help you to come out with some good recommendations for the parent and the caregiver at home. And as you see here, we divided what you do in the office, which is very important, what you're going to be charging for, do it in your office for the child that visit. What you leave the parent to do for the child themselves at home for those almost 9,000 hours that they have to do every night, at least every night, to make sure the last thing that brushes their child's teeth will be the fluoridated toothpaste. And number 3, what kind of recommendations you have for the caregiver yourself? Even though as a pediatric dentist, you're going to say, but Dr. Ramos, I'm a pediatric dentist, I don't see adults. At least your responsibility to make sure that they have a healthy mouth, because whatever happens in the parents or the caregiver's mouth will reflect to the child or their baby. It'll be like a mirror. So you want to ensure they have a dental home as well. So we have these tables. These are for 3 to 6. This has helped us. Again, we are in the process of updating this based on science and evidence. This is a moving target as well. So it's important that we add all those things. But the key is that you have a whole array of preventive interventions that you can really take place for these families under 5 years of age. So everyone asks me all the time, tell us about what kind of products for combination therapy approach. So even though this is a Colgate sponsored session, you guys know me, I talk about everything that I use, which is a combination of different products by different companies. So I'm gonna make reference of what it works in my practice and how we do, especially with the focus of remineralization of the enamel, which there's not really any or good clinical trials with evidence to showcase for primary dentition of young children. Remember that our whole focus is on a remineralization process where we can really create fluorapatite after demineralized surfaces to really have some remineralizing for early lesions and really make a trigger change from going from demineralized enamel to remineralized enamel at any given time. So that's an important thing that we need to address as well. So fluoride, and you know that it's our main and most important weapon, inhibits demineralization, enhances remineralization, inhibits bacteria there. Water fluoridation, we have 75 years of an amazing success story of public health services for water fluoridation in this country, in the US. We think there's nothing better than to really try to promote tap water, filter tap water, either with some of these devices, breathe up her, or you can actually just boil the water, which will be safe, it'll be more cost effective for the families, and they will not spend so much money carrying water in big jugs or some other places. So it's something that we like to emphasize. And again, going back to the use of fluoridated toothpaste, is our #1 weapon, right? The recommendations are small smear fluoridated toothpaste for children under 3 years of age. And then after 3, you can base it in their possibility of them to speed or knowing how to speed properly. You then switch to a half a pea size or a pea size so they do not ingest the toothpaste to create some consequences of fluorosis in the future. These are the guidelines of the ADA, which are essential: the smear amount under 3 and the pea size, half a pea size for children above 3 to 5 years of age. For me, I think this is such an important concept that we need to be advocates. All of us in the Zoom today, please send a message that are unclear in your cities, in your counties, in your communities, which is relevant. It's our #1 most universal weapon against early childhood caries. The early recommendation of the use of a smear amount of fluoridated toothpaste, not just any toothpaste, fluoridated toothpaste, which also there's a controversy because some countries have like the 500 to 1,000, and all the evidence shows that really the 1,000 is the minimum amount that can really help better for this remineralization process at an early age as well. So the whole concept of helping them brush, parents are also not aware. They have to be assisting and monitoring their child's brushing until they are 8 years of age. It's an essential part of the practice. So it's so important that you guys really try to give parents some tools, some videos, some resources, and some tips, because the #1 that parents struggle with, you have to agree with me that first number complains, Dr. Ramos, he's not brushing, I don't know what to do, it's a fuss. At the end of the day, when everyone is so stressed out, it's the last thing you want to fight. So the American Academy of Pediatrics has come up with a great project of reading a book, brushing the teeth, and maybe singing a song, or is such an important thing that to make the brushing as a bonding experience for the families and the parents with their child. Almost like starting very early on, adapting to the behavior of brushing will be almost like changing diapers or washing the baby's hands. You know, making it like a daily habit that you don't have to think twice of struggling at the end of the night or the day. So it is important that you really spend some time and give their individual ideas, resources, or counseling to parents about brushing techniques at home will be essential. So as you know, there are many brands of fluoride varnishes. So there's several in the market that are out there. I mean, we've been using Colgate, the Preventive varnish, but as well, we like the CleanPro, the 3M SP, since it has the calcium phosphate and fluoride. It leaves a nice sense in the mouth as well. And we've seen some great success stories. For those early demineralized white spot lesions, we use like a way that we can ensure that hopefully these spots will be addressed properly. So this is a case that we have about some very incipient caries lesions in very early primary molars. So the question is, you know, what would you do? And the way we teach our residents is to really think about many options of minimal invasive, especially now. I mean, are you going to go and just do the class 2s or do crowns in there in this child? Are you going to look at the overall mouth? What are you going to do? So we try to start with step 1, or the phase 1, which is trying to remineralize those lesions. For me, we need to really work on trying to bring from these incipient caries lesions to hard enamel and arresting the disease progression, which is essential. So Dr. Manway in Harvard Children's Hospital, she has a protocol with GelCam that is really very good. She has great success. We use it also routinely here at UCLA. We also move for very severe caries lesions, and I know this might be some controversial because they say, but you cannot recommend 5,000 parts per million toothpaste for young children. So what we do, we buy those small little pill boxes. We never give them the full toothpaste of Cleanpro or the Prevident, so we squirt almost for a month, and we tell the mother or the caregiver, your child has wounds in her front teeth, D, F, and G, for example. Do you see the wounds? So brush with regular toothpaste, as you have to do normally every night. And let's just see, just for 1 month, take a little bit of a Q-tip, and this is a very strong medication and drug that we're giving you. It's child-proof in the cap, so no one can really get access to it but the mother. So just put a little bit in the Q-tip and paint where those wounds are in your child's teeth. I show the parents very well. We tell them, we show them, and then we let them do it. So she can just heal with a bit of the Cleanpro 5000 or the Prevident to go through these lesions. We call it a shock therapy approach. This, A, the families and the parents that we monitor very well, that we know they're gonna continue coming. B, we address the behavior that is causing them to start with this demineralized enamel. I mean, no matter what you put in there, the mother keeps giving Coca-Cola in the bottle at night. There's no miracle or magic you can do, right? So we really need to stop the behavior and to find out what a behavior that is causing this demineralization process. And then we give them the amount of toothpaste just a month, so they can go home and do it routinely every night to see then what is the event of the lesions a month, 2 months, and 3 months later. And we monitor them very well. For those interproximal lesions, like I show you, incipient caries lesions in the back molars or even in anterior incisors, we do the flossing technique, which you can put actually the medication in there, like a little bit of the Cleanpro or the Prevident in there, and we leave it in between, we pass it. So this every night, remember, the constant exposure of that toothpaste will really do some very nice things to remineralize enamel in those primary teeth indentation. So what is the future? In the future, we need to really come out with a combination therapy approach that uses varnishes, gels, toothpaste rinses based on age and based on the risk of the child, which is such an essential, relevant, and important mechanism in which you guys are gonna do with your risk assessment, a very good appropriate diagnosis first and foremost, and then a good treatment plan. So this is a little bit of our armamentarium for these young children with some of these toothpaste. For me, these are my favorites that we've been using with great success. And again, anecdotally, we have not been able to do clinical trials in 0 to 5-year-olds. But the whole idea, and I guess COVID came to hit us with all the challenges of non-surgical procedures or restoration. So it becomes really handy to look at these protocols and see, again, which ones will be most appropriate before you get into your hand pieces, into the drilling and the filling, and all the amazing opportunities we have now with ITRs, intermediate therapeutic restorations, or PRRs, which are really the efficacy of glass ionomers. I mean, it's our bread and butter in pediatric dentistry. You cannot really do or live without glass ionomers for us. Also think about this dual therapy approach, since I mentioned to you that a caregiver with very poor or bad oral health will have, unfortunately, a baby with poor oral health as well. Their prediction is not very bright for this child. Therefore, it's very important that you use or that you recommend some sort of home care for the parent and the caregiver based on their own needs. And we have a whole array of these combination therapy approaches, right? So moving into the minimal invasive dentistry, we are also placing sealants in very young children. So calling them sealants, not resin sealants, glass ionomer, protective restorations, maybe they refer better. We completed a study, the GIVE study, the glass ionomer fluoride varnish, where we use triage to really, in those very, very severe extreme risk cases of ECC, to really have this appropriate intervention of sealing their primary molars by age 2 and 3. We have an amazing opportunity to train dental assistants with extended functions, almost like community or healthcare workers that had work that are supervised by dentists here in California, that we can actually work with them to apply these protective restorations in very young children. And they can really do it better than any of those if that's all they do every day of the week. So we have some great success stories on that. So the idea is that before you jump into all these restorations, that you think about or stop before you go into a crowns or class 2s, or really getting much more aggressive, to really think what are the kinds of steps you can take before before you can even consider a much more aggressive restorative treatment plan, right? The whole idea is that you can always go back to the crowns if you need them, but you at least attempt to do first steps before you get into this restoration course. So these are some of the molars from our study. To glass ionomer seal primary molars by age 2 or 3, we call them graduation. They come to see us by age 1. And by age 3, 4, 5, they already finish with their older molars, especially all the high-risk children that we see with very deep grooves in their primary molars. We seal them. We do protective restorations with glass ionomers. The beauty about this glass ionomer is that you do not require to have a very dry tooth, and all the isolation is required like you will do with an appropriate resin sealant. But the beauty about glass ionomers is that you can work with them in moisture surfaces, right? So the idea is that, and remember, our outcome is not the protective restoration or the sealant longevity, but our main goal is to really reduce the amount of early childhood caries that this child might have, or caries progression in their primary molars. So it's a different outcome, because people are going to say they don't last that long, but guess what? In our study, we had very, very surprising and very interesting retention rates that we're not expecting from the glass ionomer in primary molars. So this is what I love to see, a generation with all these babies from age 1 that you can really monitor properly, risk assess appropriately, do the re-care. If they need to be seen by you every month, to see them every month. If they need to see you every 3 months, see them every 3, every 6, but not to really standardize that one size fits all doesn't work at all, because Rosita might have to see us every month, and Johnny every 3, and maybe Paul every 6, right? So it's really based on risk where you're going to do your recurrent systems, and that you really provide for them the most array of preventive measures before 5 years of age. So this is another aspect of our triage gift study where we seal those things. For older children, obviously, you like to really use the use of sealants. It seems that they're totally underutilized. All the data shows that dentists are not really doing an appropriate marketing and an appropriate really conveying to the parents the incredible benefits of the use of resin sealants when the child is older, at 6 years of age and 12 months of age, especially for the permanent molars, which is something so important to do. So there's also a ClinPro sealant that I like. I'm really moving for combination therapy approaches where you have dental materials with calcium phosphate and fluoride, right? Now, everyone is excited about silver diamond fluoride. I cannot omit. This is an amazing, extraordinary, extra tool in our bag of tools. It's not the only one. It's another additional amazing resource that we have for children that are already more affected, that they're not ICDAS 0s, 1s, or 2s, but they're more into the 2s, 3s. But to be cautioned, because also there's some contraindications in very severe deep caries lesions that SDF is totally contraindicated. So we use it routinely now for several years. We love it. It's part of our armamentarium for minimal invasive. So let me tell you where we have got into trouble and where I've heard people has got into trouble. There are three contraindications you need to be fully aware consent, consent, consent. You have to document, you have to explain the parent or the parents before you do the treatment of what it's going to do, the blacken of the teeth. You don't want parents to be surprised or to be shocked since you never explained to them. Our consent forms have been switched now to have pictures of the tooth and then the blackened tooth. So there's no doubts of what it's going to look like. And if they have a spouse or a partner or someone at home that they need to really convey this information, we give them information and we ask them to come back after they both had agreed on the care of the child. Consent, consent essential. Second contraindication, the staining. You know, sometimes people are using less is more. 1 drop per quadrant is the best and the most beneficial that I see. When you use a lot of it, one of the residents years ago, you know, when we started using it, they had it in the glove. She didn't realize she had it in the glove, and then she touched the child's cheeks, the lip, and the child came out with a tattoo or staining, like if they had punched the child. The mother was upset. So make sure that it's very, very technique sensitive. So just use a drop and put it in a separate place, and you know exactly where it is. Now that they come with a blue way, then that's great because you can see the blue in there. And lastly, you know, you don't want any surprises. It's totally contraindicated in very deep carious lesions. Any IC that's, I would say, borderline 4s, 5s for sure, and never in 6s. That you will use it. Why? Because if you even think, or you even are concerned about indirect or pulp exposure, you should never, ever even think about SDS as your treatment of choice, because what happens is that this is very, very exacerbates pulpitis, and then the child will come with an infection or an abscess days after, and you don't want that, especially if you're using this for behavioral cases that children have issues dealing or coping with the dental environment. So it was a nice video to show that also you can use some, with great success, the use of SDF in interproximal surfaces, even for those incipient lesions, that you can maybe go in there and just pass your floss with the SDF and have it in those lesions interproximally. We're all excited about the SMART technique, the silver modified traumatic restorative treatment, which is a combination of SDF and glass ionomers, which is a wonderful, amazing other layer and level of minimally invasive pediatric dentistry we're so excited about. So we follow from Dr. Pitts, Nigel Pitts, the guide for practitioners, you know, that was done, where you really have to put all these pieces of the puzzle together: your caries risk assessment, your charting, your self-management goals, all of these things with effective communication to really, really come out with good remediation modalities based on recare and based on the treatment patient needs and preferences. So I have a case here of a 2-year-old. I'm not gonna go much for the case, but just to show you how we use for each of the cases, based on their age and the risk, we can high point and highlight from the care paths that I share with you that we created, that you can come out almost like a little cheat sheet of some of your options you have for treatment. Let's move into people. They've been asking me so much to address the issue of COVID. What are we doing now after COVID? Our lives have changed dramatically. You know, I don't have to tell you how all of us have been affected. But we've been part of the CDA, the California Dental Association COVID Task Force, where we really, it was very clear to us that it was not just PPE we have to be concerned about, but there's a whole framework for mitigating and reducing risk of transmission. So one is elimination of the biohazard, the engineer control. So I want you guys to be very familiar with this triangle. We just wrote a couple of papers on this. Also the administrative controls, which is all the kinds of things that you think about in your treatment plan, and then comes the PPE, right? So something to keep in mind, there's not just PPE that counts, but all these different factors to be most effective. So you all have struggled with PPE, what are the surgical masks, all the things we have to change on the personnel. But I think one of the silver linings, you know me, I'm trying to look at the positive of this, because like all of you, we were from shocking to anger to depression to like, oh my God, what's coming next? So now we have to be creative and focus in what can we do to improve our access to care and our services. So teledentistry is here to stay, telehealth. I think before we start using it, but now we for sure, we are really relying heavily on telehealth, teledentistry, where we can really be able to connect with the parents and the families in a more appropriate ways. So we still are doing the risk assessments through telehealth. We learned that there's some etiquette, and I have a whole class on telehealth or teledentistry etiquette of what the do's and the don'ts. But I'm not going to spend too much time on this. I hope that you all know that we have to really train ourselves and our staff and our residents and students to the telehealth do's and the don'ts about what's happening in the session. And also the families. The families have to really understand what are we planning to do. Telehealth can help us also with data connection, with monitoring patients more appropriately from their homes, from their households. There's a whole mechanisms where we're looking at different platforms that will allow us to really do this teledentistry telehealth, where has to be a double interaction where parents now are sending us pictures, they're answering the risk assessment tool and goes into the telehealth, COVID questions, medical history questions. And it's really a wonderful tool now. I know that we're all zoomed out. I'm the first one to tell you that I'm very soon burnt out, but again, we have to really start thinking into the culture of telehealth sessions as our routinary practice of pediatric dentistry. So let's share with you a little bit of some of the examples we have done. Remember, our whole purpose is that we have a cohort that we left for almost 3 months where things changed drastically in the household. Parents were giving foods, they were quarantined at home. Sheltering in home is not the same for everybody. I think we're all in the same storm, but very different boats. Some of them are just trying to stay afloat. So we have to be very sensitive and very, very understanding on some of what these families are going with. So we also learned that a lot of the families have access to technology, to their cell phones. So we taught the parent, there was an IAPD wonderful video that came about showing parents in a video how to take their pictures, right? So the idea is how we can actually get pictures of babies and infants that can be useful for us, that they can send to us. So we've been practicing with parents, and I'll show you a whole array of pictures, how good is home picture taking and sending them to us in an interactive way, because we're relying heavily, especially at the beginning for the emergencies, for parents to rely heavily in their child's pictures. So we have from the great, the amazing photographs, photos to like not the very ugly and the bad ones. So we have a whole array. But the whole idea is that how can we really start taking the parents, training for them to take the pictures from home. So we have a whole pre-appointment screening that we have to explain to the parents, where they do the medical history questionnaires, consent, the Caries risk assessment, the camera, and COVID questions as prior, like the pre-screening process of their visit. We also, and I downloaded in the website for you today, also our videos. I wish I had time to show you, but I don't think I have. On brushing techniques, how to teach parents how to detect the first signs of caries with the white spot lesions, and also a manual of how to take oral pictures using home equipment. So this is a little bit of the videos that I send it to you. I'm not gonna show them now, but you can watch them and download them at your leisure. Also go to our website as well to look at them. We did infographics for the parents, which are very, very helpful about how to integrate the remote care as well as the access. But now we needed to see them as phase 2 in the clinic, and we're not allowed to, so we had to be very creative with a drive-through, like almost like McDonald's. So we thought we could do almost like testing for COVID drive-throughs. Why couldn't we do a fluoride varnish drive-through of infant oral care? So we have a big parking lot outside of the clinic. So we came up with a tent for us, like a dental screening place. We thought it was very safe for the staff and for the families. These are some of the drive-through clinics where the child is kept in their car seat and they come around as part of the hospital setup, and we are able to do and provide some of these services in there. So this is very, very friendly, user-friendly. The idea is that we can maybe take extra pictures at the time of the car seat. The visits are from no more than 5 to 10 minutes just for clinical care. We take the picture, we look at any lesions, any problems, and then we apply the fluoride varnish, and then we schedule them for a Zoom meeting to do their anticipatory guidance. So this is one of the, how we had to change everything, almost like a drive-through, like a McDonald's for Florida Varnish, just some food for thought for some of you. And then we discuss the cases. We have still our residents and students where we look at the medical histories, the consent forms, they're all recorded and monitored in their EDR records. We look at the Caries risk assessment tool, and when we do the COVID. And these are some of the cases. These are the pictures that the parents have taken for us. 3-year female, what are the risk factors? What are the protective factors? We discuss the cases for interaction with the parents so we can come out with a good treatment plan in minimally invasive. So these are just some of the cases that we've been collecting. So remember, I took this chart from Dr. Dominic Zero. He allowed me to use it, which I really love about. I want to show you what the future for us will be all about, where we can really think about focusing on all the areas of prevention, in primary prevention that you see in there, all the array of things we can do for patient services before we get in an initial caries with non-surgical approaches as secondary prevention, and really always go to the last resort where you need to do surgical to then maybe move to a tertiary prevention care approach of restorations, right? But you have a whole array of the green, the blue, and the purple. You have 3 whole layers of involvement and interaction that you can do. So to finalize, just some tips to give you. Sesame Street just came out with a whole array of videos on brushing teeth. So please go ahead if you have a chance to look at them. They just came out, they're brand new. Go to the Sesame Street website, Oral Health, and you can find them as well. The World Health Organization, remember, moving into policy changes, the World Health Organization has come out with really trying to decrease the amount of sugar intakes for young children. We're really trying with IAPD, as you know, to promote infantile care. 2 will be already, it's too late. We have to really think about caries-free generations. The IAPD, as well as the FDI, have come out with statements like this one, the perinatal and infantile health. The IAPD with the Bangkok Declaration, I think, really are shouting to the world the need to all of us conveying into really having these recommendations from the IAPD Bangkok. One of the things that we really wish we could add to the Bangkok Declaration will be the focus on really home care and making sure that parents follow some of the recommendations. We wrote several articles and commentaries and positioning children's oral health as an issue of equity, social justice, and human rights. So we hope that in the future we can add oral health into the UN for child protection services. So remember, all the ethicists, all the people think that the only way we can really create equitable and improving access to care will be that promoting and implementation of the H1 visit throughout the world and the different countries we're a part of. So we have a Center for Children's Oral Health. You're welcome to go and to look at all the resources that we share with you today. If you have any questions, you can also get us on our websites. We're revamping our whole pediatric dental curriculum. And we have our whole website of UCLA Infantile IOCP Infantile Care Program that you can download all these resources in different languages. And with that, I'm going to stop here. Thank you so much. Namaste. I know all my friends in India and other countries it's almost midnight. I'm so appreciative and so grateful to be part of the IAPD family, first and foremost, but also to have you here with me today. We're all in this together, and only united, we can make a huge difference. Thank you so much. And with that, I'm going to stop.
Thank you, Dr. Ramos. It was a wonderful presentation you have delivered. We learned a lot. There are many questions asked by the attendees. Some of them I will ask to you. Dr. Kaval Preet asked about which is the most effective tools, camera or CAT?
Camera cuts. You know, they're all very
CAT. Yeah.
Yes, they're all very similar. Of course, they'll have different nuances. I think the key, whatever risk assessment tool you use, make sure you have the 3 domains, right? Regardless if it's camera or CAT, I think both of them have it, as well as the one that the AP has, which is the risk factors, the protective factors, and the clinical findings. So you can put all those 3 together, almost like the checklist of the captain or the pilot on the plane, we need to have checklists to address, to do very diagnosis, very patient-centered approach, and definitely have appropriate options on minimally invasive to aggressive dentistry for every child in a very patient-centered approach.
Thank you. And her second question is, at what age xylitol wipes can start?
At what age? I'm
Xylitol,
sorry.
xylitol. At what age xylitol we can start? Yeah.
Oh, xylitol
Yeah.
thing.
Yeah.
So, you know, xylitol is been proven to be effective with the wipes. You know, for adults and caregivers, it shows. The only problem with xylitol that we're finding is that we cannot recommend gum chewing to the parents at all because they're getting some TMJ issues. And also remember that the challenge with xylitol is that you need to have 4 to 15 grams per day, every day, to sustain the protective approach. So it's very few families that we see that they really stay and keep the habit, right? I think better than moving to xylitol just to promote the use of fluoridated, universal use of fluoridated toothpaste will be an amazing, incredible success story. We can all, in unison, make sure that all these children are already exposed to fluoride toothpaste from the first.
I think we are encountered with some problem.
I think we're done now.
Yeah, no. Actually, we have some encountered with some problem. Dr. Neka
It's okay.
asked,
I think we finished it already, so that was very good.
yeah, so you can hear me?
Yes.
Okay. Dr. Neka asked about your opinion about arginine toothpaste as an alternative to fluoride toothpaste in management of dental caries, ECC.
Yes, I have
Arginine.
no experience using arginine. I have no experience using arginine toothpaste in young children. Sorry.
Okay.
But if she has,
And
please share with me her experiences. I don't think there's in the use as for us to use.
Dr. Bhampya asked about the can glycinoma sealant replaced with resin sealants?
It depends the age of the child and each case, right? So it's not replacing one of the other. I mean, we are very success stories using glass ionomers and smart techniques in very young children. The older the child is, you can start thinking about more long-term resin restoration.
Okay. And Dr. Ami Harhap asked about, do you experience using ICON, that is Caries infiltration concept?
Yes, so I use Icon. I mean, it's also another layer of expense. Icon is not cheap at all. If you can maybe open with some orthodontic bands that space in between the teeth and just apply some SDF, and if you can maybe place or paint a little bit some of the glass ionomer in there, I think will do the same as Icon, right? And Icon you'll use for more maybe teenagers or permanent dentition.
Okay. And one question is from Dr. Arena. Is there any protocol used at UCLA for taking pictures in teledentistry?
Yes, so we've been struggling also with that because it's not easy. Parents are very challenged to do that. So they require some hand holding. We have a protocol that's in our website that she can go and access as well. I know that the IAPD shared a very nice video, which I hope that they maybe share with the resources I think someone in Glasgow put it together in the UK. But we're gonna be having our video also that people we can disseminate. We want to share all the resources we have in our website. You are downloadable, and they're in many different languages. So they're all for you to use.
Okay. And I'll take one last question, Dr. Mani. Can SDF replace application of professionally applied tooth fluoride treatment?
Can
Can
SDF
SDF replace application of professionally applied fluoride treatment?
They're very different. Please don't be confused. There's no replacement. The fluoride varnish will be for every child healthy, with very slight decalcification of the enamel, even for any child that's affected. SDF is a curative effort, a progression of disease for young children. And what it will do is that it will actually be halting or arresting the decay process when already it's in place. So it's kind of a secondary use after the regular fluoride varnish application. So I don't think one substitutes the other.
Okay, thank you very much, Dr. Ramos.
Thank
if you have time, I can take one more question if you
I think
permit.
that I'm just afraid of people's timing, but yes, whatever you want, I'm here.
Okay, Dr. Julius wants to ask what interdental cleaning measures could be recommended for children with the primary dentition? What
So it depends on the
interdental cleaning?
space, right? Usually they have spacing in between, but if they're very tight spaces, there's some of those little flossers, child flossers that you can give to the parent, or you can buy, or teach the parent how to do it. But it's also, again, it's all about time. You have to spend time with the parent and the caregiver. You can just see them in and out, right? You need to spend time, spending time with them. They will trust you more. They will do more effective in your communication of motivation, interviewing with parental engagement, and really, really learn that one size does not fit all, right? So you need to really work with the families based on their needs and their preferences. That's something that we keep forgetting. And it brings you back to this logic and this common sense of everyone wants to be treated in a special way, right? So based on the age of the child and the risk, then and their conditions, then you're gonna then come out with a whole array of different recommendations, but only two, remember, only two each visit. So you make it a very doable plan for the parent. You have no idea. They do not know that I'm on that clinic only once a week. I mean, they call my office, they send me messages. Oh, you know, I was able to take that child off the breast. I was able to take the ball out. I mean, they're so proud. All they need you is to become a health coach, a manager, someone that they can rely on you, that they're not alone. And together with you, you'll really get and achieve the best well-being for that child at every given time as you provide.
Thank you, Dr. Ramos. It was a really
so
wonderful presentation. It always, I love to, listen you.
He's my friend. Many thanks. I wish you all the best. Stay safe. We're part of the family together. We love you.
And same to you.
Thanks again to IAPD and Colgate for this great opportunity.
Yeah.
Well, enjoying the rest of the lecture, and the organizing committee, Lorraine and Davna, thank you so much. You guys are brilliant. I appreciate all your help and support. And be well, and we'll see you soon. Please join in tomorrow for an amazing set of lectures for IPD. Have a good one. Take care.
Thank you.
Bye-bye.